It's my pleasure to introduce our next speaker, Dr. Theresa Lee, an anesthesiology-trained pain management physician and currently a postdoctoral research fellow at Stanford. Of note, she's also the first author on the paper randomized trial of ketamine masked by surgical anesthesia in patients with depression that I think our audience is quite familiar with.
It's very controversial.
So I'm looking forward to a great discussion. Today she's going to talk about opioid use diminish placebo antidepressant response independently of pain in a ketamine depression trial. Thank you.
All right. Everyone in the back hear me? Okay, good. So thank you so much for giving me the opportunity to present at this conference. I'm really enjoying everyone's different viewpoints and studies by mechanism of action. It reminds me of that one parable where it's a lot of blind men around an elephant and they're all trying to figure out what this elephant is. And I think we're doing that right now. So hopefully we can all come together and figure out what this elephant is. But my viewpoint is going to be still rather narrow from one blind man's view. So I have very few disclosures. My salary is funded by the National Institutes of Health and some clinical work. I have no financial conflicts of interest, and my presentation includes the discussion of off-label, obviously, and investigational uses of ketamine. So let's just start with the punchline. By the end of my talk, I want to convince you all of two things. One is that I think the antidepressant effects of ketamine and placebo are both dependent on the endogenous opioid system. And this does not mean that ketamine is the same thing as a placebo. So I don't want the takeaway message to be this, and even though it might seem that way. So why the opioid system? So fortunately, my talk has been sort of set up already by the previous talks, but I'll go through these bullet points rather quickly just to be thorough. So first is that NMDA antagonist candidates have so far been, on the whole, kind of underwhelming in clinical trials for depression. So it makes you wonder, is there a contributing pathway or mechanism or a different pathway that's totally independent that's driving the effect of ketamine? Second, ketamine is known, especially by pain physicians like me, to enhance opioid sensitivity in chronic pain patients. And the proposed mechanism behind this is that ketamine somehow potentiates mu-opioid sensitivity or signaling in vitro, and hopefully this will be demonstrated in vivo as well. Also, endogenous opioid system dysregulation has been implicated in as a potential mechanism underlying depression, particularly treatment-resistant depression. And as discussed in previous presentations, ketamine has abuse potential. And talking to some practitioners out in the community, I'm not speaking for all of them, there's a sense of maybe excess security that if you give ketamine in the setting of ketamine-associated psychotherapy, that you're safe and it's not going to be a high risk of addiction. And I have some bad news. So I recognize that Reddit's not exactly a replacement for peer-reviewed research, but I think it's actually a good window into what's going on in the real world. So for those of you who don't know what Reddit is, it's basically an online collection of message boards that basically cover every single niche topic you can imagine. And so this is on the message board for ketamine addiction. And literally, I think 3 posts down on the first page, I ran into this just a couple weeks back when I was putting these slides together. This person says, I started to be using ketamine for ketamine-associated psychotherapy for treatment-resistant depression. In the same thread, people respond, yes, same thing. My issue with ketamine started after KAP for TRD. And people just kind of piled on and said, yeah, it was a wonder drug at the beginning, but I just kept using, and then I was shooting a gram a day and wanting to die. So anyways, the risk is out there, and we have to wonder, what is the mechanism? So, we just saw this. Thanks, Alan. So this admittedly small study, but well-powered study nonetheless, showed that if you gave naltrexone, that the effects were attenuated in ketamine responders, and that this was independent of dissociative effects. But why do we think naltrexone blocked ketamine's effects? There are a few possible explanations. One is that ketamine just directly activates the opioid receptors, and it's certainly possible, but we know that ketamine is a rather weak direct mu-opioid agonist, so there might be other mechanisms. Ketamine might stimulate endogenous opioid release, or kind of a slightly different way of looking at it. Naltrexone disables the placebo response system, which might be needed for ketamine to work. So kind of going on a slightly different track, but very related, is the mechanism underlying the placebo antidepressant response. And we think that, we, as in maybe a few folks who are studying this intently, we think that this is opioid mediated. So there's some very cool research done by a group led by Marta Pesena and I think John Carr-Zubieta, basically trying to answer this question in humans with functional PET and neuroimaging. And they basically showed that if you take depressed patients and tell them they're getting some magical rapid-acting IV antidepressant, and then basically run them through a radioligand study, they found that placebo-induced improvement in depression correlated decently well with mu-opioid receptor occupancy, presumably from endogenous opioids because these patients weren't taking other opioids. And then the same group also showed that if you give naltrexone to patients who are given some sham neurofeedback showing that their rapid-acting IV antidepressant, which is saline, by the way, is working, that you can also partially abolish this placebo antidepressant effect, which is pretty cool. But wait, so you might be wondering, does that mean ketamine is just a placebo and only placebo? Well, actually, let's run with that idea for a minute, because I think it's kind of interesting to kind of take things to their logical conclusion. If we assume that ketamine is 100% placebo effect, presumably mediated by the endogenous opioid system, then if you somehow disrupt or impair the endogenous opioid system, then you can imagine you run an RCT comparing ketamine to placebo, the patients who get ketamine then won't do any better than patients who got placebo in this RCT, assuming that ketamine is 100% of placebo. So can we do this? What kinds of patients have disrupted endogenous opioid systems? What about chronic opioid users? So actually, patients with chronic pain in using opioids were a subpopulation in the main trial that I published last year. And so this actually made for an interesting post hoc reanalysis of our study. But I'll give an overview first of our original study for those who aren't familiar. We recruited 40 adults with moderate to severe levels of depression who were just so happened to be scheduled for routine major surgery. The intervention, obviously, was a psychiatric dose of IV ketamine, so we try to keep this as consistent with the previous studies as much as possible, and we compared it to an equal volume of saline. So both the ketamine and the saline were given under general anesthesia, basically while patients were totally unaware. And the outcome that we studied was depression severity as measured by the MADRS over the first 3 days after their infusion. We did follow them all the way out to 14 days out of curiosity and potential for secondary analyses. So our main trial findings. Just to orient folks, x-axis will be the day relative to infusion day, which is day 0, and the y-axis shows the depression severity measured by MADRS. And as you can see, patients on average had moderate to severe levels of depression at screening, and this persisted to the pre-infusion measurement on the day of their surgery. Then on the first, second, and third days after their surgery and after their infusion, as you can see, both groups improved in depression scores really dramatically. And if you look at the effect size of this and the amount of points that they went down on the MADRS score, this is virtually identical to previous studies done in awake patients. And when we followed them out to 14 days, this actually persisted. So this is actually an interesting finding because I think a lot of these older studies find that by 2 weeks that the effect of ketamine goes away and patients are back to baseline. So then we asked patients at the end of the follow-up period at 14 days to guess what treatment they received before revealing it to them. And as you can see in both groups, ketamine and placebo, they kind of had similar distribution of guesses in both groups. They're not really significantly different here. So we concluded that the blinding was affected because there was no difference in guess distribution. And there was a bit of optimism, as you can tell. Most people guessed ketamine. And an interesting post hoc analysis or reanalysis of our findings found that folks who guessed ketamine tended to feel better. It's kind of as expected, but it also demonstrates that there is an expectation of benefit. So one thing that came out of this and sort of thinking a lot about what our study meant is the idea that perhaps when the blind is truly maintained in a randomized trial and patients have big expectations about their treatment helping them, and you combine it with some kind of salient event, a big event like a surgical procedure or shamanistic retreat back into the woods, but some kind of big event, that this may lead to a dramatic treatment effect regardless of what treatment they get. So just something to keep in the back of the mind as I go through the rest of these slides. So I want to talk about basically the title of this slide, the reanalysis by opioid use. Of note, in our main study, we had excluded patients using large amounts of opioids, more than 90 milligram equivalents per day. Also, we excluded folks using opioid antagonists and buprenorphine as well. And just to get into a little bit of some of the baselines, you get a sense of how many folks were using opioids. 35 to 45% of our patients were using opioids at baseline or screening. And characteristics at baseline between opioid users and non-users were similar in age, sex, BMI, duration of their depressive episode, treatment resistance, and depression severity. Just, these folks are pretty similar. So in our reanalysis, we noticed that pretrial opioid use reduced the antidepressant response in the overall sample of 40 patients. And there was a substantial difference in the primary outcome here in the first 3 days after their infusion. The 3-day average MADRS score is 20 in folks who were using opioids and 13.5 in folks who were not using opioids before their surgery. And so just to put things in context, this is like the difference between moderate severity and mild severity of depression. Now here's where things get interesting. We performed a subgroup analysis by treatment group, ketamine versus placebo. And we found that the placebo group was driving the results in the overall sample. This also means that the placebo antidepressant response, which you see here, is smaller in opioid users compared to non-users. And conversely, in the ketamine group, the antidepressant response seems to be preserved. And what about pain? Obviously, these people are having surgery and they're taking opioids. Like, why are they taking opioids? Presumably, they have pain. It's a very intuitive guess that maybe the pain might be inhibiting the antidepressant response or the placebo antidepressant response in these folks. Well, here's what we found. Actually, if you looked at preoperative pain intensity, they did not predict postoperative postoperative depression scores in simple linear regressions. These are all post-hoc analyses. And individual correlations between depression and pain intensity was quite weak, although as expected, opioid users did have higher post-op pain intensity. But just scatter plot just basically shows you can't say that folks who were having more pain were also having more depression. So what can we conclude based on these findings? So we found that previous opioid exposure reduced the placebo antidepressant response independently of pain, and that ketamine somehow appears to preserve the antidepressant response. Therefore, ketamine is not the same thing as placebo, because if it were, these two graphs would be looking the same, not different. There are obviously some limitations of this analysis. It's post hoc, it's got small subgroups. You start breaking down 40 patients into 2 by 2, you get really small numbers per each subgroup, obviously inflating the risk of a type 1 error. But it's an interesting finding nonetheless, and there was a lot of heterogeneity in our samples. People got different surgeries, they got exposed to different anesthetics at the choice of the anesthesiologist. So just some caveats. I want to end on this slide, which probably just reveals that I have terminally online humor, but I think the expanding brain meme really encapsulates the evolution of my reaction and other people's reactions to my RCT findings. So the first reaction is, unfortunately, a lot of media news outlets kind of ran with this line in that my study showed that ketamine is no better than placebo. It's useless. Why are we using ketamine? No, that's not what we wanted people to take away from the main study. Probably a more accurate takeaway is the second box down is that placebo is effective as ketamine. And if you start thinking about this statement, it's actually interesting. Like, why did the placebo group improve as much as the ketamine group? Is it context? Is it the anesthesia? The next step, sort of, as I went through and talked with folks about the results of my study, is that, well, okay, what if ketamine is a placebo? But then if you dig into the data, like I did and what I showed you, there seems to be some kind of interaction with opioid use, maybe the endogenous opioid system, and maybe perhaps this leads to the hopefully testable hypothesis that ketamine restores placebo pathways as its mechanism, or a substantial mechanism, probably not the only one, for treating depression. All right, well, lots of time for questions. I want to thank everyone. My key mentors for this trial, Alan in the audience, and my mentor, Boris Heifetz, who unfortunately couldn't be here today because of lots of conflicting conferences, but he says that he wishes he could be here too. Lots of other collaborators in our lab contributed greatly to the study.
Thank you. Thank you. I'm sure you will be getting lots of questions. So I think somebody raising their hand. It's over there. Can't see really.
Hey, Theresa. Great talk.
There you go.
Well, I guess two slight questions. One, did the patients have any differences in how much pain meds that they were taking post-op?
No, in post-op, no. Actually, both for opioid users and non-users, and also if you split it by the treatment group, there are no significant differences in at least inpatient post-op opioid use. We didn't, we didn't track outpatient quite with enough granularity to make that distinction.
And then a second, kind of unrelated question.
Yeah.
So you heard earlier that context during ketamine treatment seems to matter for the expression of the effect. So are you implying that, is it too speculative to say that then the opioid system is involved with that contextual processing?
Yes. In sort of like our lab's post-mortem of our RCT, we were at first concerned that perhaps maybe we were too nice to our participants, and perhaps that caused the substantial placebo effect. Robin Okada is our main research nurse in our lab, and she is literally the nicest person on this planet. And she talked with our participants, like hours for the whole study, right? So many interview questions, validation. A lot of our patients, it was the first time people had listened to them about their depression symptoms. So yes, to partly answer your question, one, I do think it has to do with the endogenous opioid system and basically recruiting that system to produce an antidepressant effect. But also to address maybe some folks' lingering question of like, oh, surgery kind of seems like a nasty environment to get ketamine. Like, why did people get better? Actually, it's probably even like more expansive than just the immediate environment. I think it's a lot of interpersonal connection that is also important for therapeutic benefit with or without ketamine.
Some question? Oh, sorry, we have a question over there while you're there. Tiago.
Thank you. I could not really understand the last expanding bearing box.
That's
Please.
Okay. I think you have to be kind of online.
I understand the general concept, but I cannot make a line for me to write to my own understanding. I could not wrap it up. Can you explain me again? Only the last one. How you get there, I get it. But
so,
what it means in clinical practice terms,
I hate explaining a joke, but I'm going to do it. This is what happens when I try to be edgy with my humor here. So basically, the expanding brain meme is kind of like a series of thoughts going from maybe a too basic, as you can see, small brain thought And this is where I kind of throw a lot of media companies under the bus for getting the interpretation of our study kind of wrong. But then as you go towards the path to enlightenment, your brain expands as you progress towards different thoughts and an evolution of thoughts. And so that's where I said, at the beginning, when you first look at the study, and if you don't think any harder about maybe the surface, then it's like, oh, placebo is, ketamine is no better than placebo. And then if you kind of start thinking about the nuances of the study, you're like, oh, wait, well, placebo is just as effective. What does that mean? What's the mechanism? And you get to a point where you're like, oh, maybe it's the opioid system, because at least in our limited population, the opioid users seem to not have as much of a placebo antidepressant effect. Why is that? So anyways, I hope that, does that make it a little bit more?
The placebo pathways is something that I could not understand, I believe, in this sentence. Maybe something.
Yeah, what is it? Placebo pathways. I mean, this is probably just a limitation of the square on this image. So basically, molecular systems level mechanisms that underlie how the placebo antidepressant effects work. That's what I meant to encompass by the phrase placebo pathways.
I think we have some more questions.
Yeah. Theresa, great talk, and I really like that progression.
Okay, thank you.
That really does capture it. I mean, I think it is important to say, too, that we didn't mention that if you put much stock in some of the molecular mechanisms about the glutamate surge or the blockade of habenula activity, simply being under full anesthesia may prohibit those effects anyway. So I think we have to be aware of that. I know there were some measures in there to counteract that.
I knew somebody would bring this up.
Set you up, but I think it doesn't impact the main point of the talk. Go ahead.
No, I was going to say, before we get too wrapped up in it, I want to say that, the effect size that we have was very similar to all these other old studies that have been done. And if anything, you could argue that anesthesia prolongs the effect of ketamine and placebo. Because a lot of these studies, the effect goes away by 1 or 2 weeks. But we didn't find that in our study.
Yeah, that's apples and oranges. These are surgical. The Kudo study, I think, had a bigger effect, right? The other surgical study. Do you have that?
No. This is kind of the lead up to, maybe not the Kudo et al. Study, but there's another study that came out in China that was a positive study.
But again, I'm not trying to highlight that. I think, it is apples and oranges there. But the main point of this, I think, is clear. And I think that regardless of what it is, it's still come to the same conclusion, at least for me, with this. It's a great study.
Yeah, thank you for the talk. Fascinating work. I just wanted to ask, so, there's a lot of talk about placebo, and we kind of view placebo as clinicians and researchers as kind of this barrier, like, oh, it's something that is kind of inhibiting our ability to show something's more effective. But do we need to kind of change the conversation about placebo more? Because with, psilocybin, MDMA, these experiential treatments, essentially it is placebo in a way, because you're basically helping someone kind of reconnect with what gets them better, which is kind of like what you were talking about. It expands the placebo pathway, perhaps. So I'm just curious if we need to start talking to the non-scientific community more, as placebo is actually not a barrier, but kind of something we need to enhance.
I agree.
Does that make sense? It's kind of a...
And I think if we do approach the non-research community about the impact of placebo effects, we have to do so with extreme care and try to prevent the natural backlash from folks who may have a very viscerally negative reaction to the word placebo. Because when you mention that something might have a placebo effect, in some folks it seems like an attack of their subjective experience. Like, oh, it was all fake and none of that mattered. And while you're not saying that directly, that might be the received message from folks out in the community. Me and my mentor, Boris, actually got some hate mail, like hate email from providers out in the community saying, oh, your research is going to take away the hope from a lot of our patients. It's not placebo. And I think we need to redirect the conversation and say, well, actually placebo should be harnessed. It might be the beneficial touch behind a lot of these experimental treatments that you bring up. So yes, we should bring it up in the community. We should just take care with how we message it.
We have a question over there, and then Mike.
Thank you very much. It's fascinating. Just a follow-up from that question. Are there other known, and by known I guess I mean empirically measurable, placebo pathways for specifically antidepressant placebos that one could measure in this than the endogenous opioid system? And then a kind of second follow-up, as we start to understand placebos better, do we then need another word for them? Because they're almost by definition an unknown, or a known unknown. So, so slightly rhetorical question.
Of course.
Linguistic question, the second one, but are there other pathways that we know about for?
Yeah,
than
so
opioid?
I wanted to go back to the slide with Marta Peseño's work, because the one where they administered naltrexone to folks who were kind of duped into thinking they were getting IV ketamine when it was saline showed that naltrexone didn't block the entire antidepressant effect, which suggests that there are maybe redundant or other pathways that exist that contribute to the placebo antidepressant effect. I'm not as familiar with the literature on, say, like the dopamine system, but if I had to hazard a guess, the dopamine system is probably also a major contributor to the placebo antidepressant effect and probably other mechanisms. Whoever's out in the audience who's a placebo expert, please feel free to chime in.
Tomorrow my talk is pretty much on this.
Oh, perfect. Love it. Love it. Love
I
it.
set you up with the other two. You said
Okay.
no.
I love it.
Mike.
Thank you for a great talk. I wonder, can I just run a potential, just a way of interpreting this data past you? Maybe I've just got the wrong end of the stick.
No, it's okay.
But I guess your results look to me like ketamine did work, but it only worked in folk that were taking opiates. And you said at the start that ketamine potentiates the effect of opiates, which we know have euphoric effects. So isn't a simpler explanation just that the reason that you see this is because it potentiates the effects of opiates, makes people feel a bit better, and doesn't really have anything to do with the placebo effect?
Well, I guess maybe I phrased it like that because the effect size of folks who were administered ketamine or placebo were pretty much the same. So I guess it's kind of like, how do you look at it? And your way is the glass is full, and maybe my way is the glass is half empty. But I think they're both valid.
But I mean, I guess if you just plot just within that, I know it's a tiny wee subgroup.
I know,
so
it's
you've gotta
super
be
small sample.
But just the folk that are on opiates before,
Yeah.
ketamine versus placebo, it looked like the lines were separate and
Yep.
they're different graphs, right? So
Yeah. Can I go back? I think we're having some technical issues here. Well, if we could go back. Yes.
You want to try with the keyboard?
Let's see. Can we go back? I think we're broken.
No, we tried.
That's okay. Sorry. But yes, your point is valid, and to me it seems like maybe the more parsimonious explanation is that ketamine is somehow restoring the antidepressant effect, or maybe the placebo antidepressant effect. But I think you're implying that maybe your explanation is more parsimonious as well. But I don't know. I think they're both equally valid explanations. You're right.
Just one last question.
Yeah, thank you so much. That was really beautiful. I'm not an MD, but Frank Anderson, MD, is doing internal family systems, and the endogenous pathways is in psychotherapy they call it, in internal family systems they call it the self-energy, and the defense mechanisms, it's the part. So actually the placebo equals, in Frank Anderson's words, love and the self-energy. So you just remove the constraint. It's a release constraint model. If you release the constraints, the defenses, you just have the placebo, you just have the self-energy, and you just have the healing, which the psychotherapist explained quite well. So I just wanted to edit
Yeah, no, I think that's an incredibly humanistic way to wrap up and end this Q&A sessions in my
Yes.
presentation. Thank you.
Thank you. Thank you very much.